afternoon. On a mission to empower you with the knowledge and tools required to unite our voices and take action this World Cancer Day, I'm Dr. Shatil from the Clinical Engagement Team, your host for today. India between 2010 2019 saw an increase in rate of cancer cases from 1.1% to 2%. While the pandemic led to a massive decline in screening, a study reported 1.4 million cancer cases in India in 2020. This year, to commemorate the World Cancer Day, Docplexus brings a 3-day event, the Global ONCONversations 2023, to address several pressing issues around the cancer gap care, where experts from across the country will participate in various clinical sessions and updates in cancer care to help the community of healthcare practitioners. Docplexus Global OncoConversation 2023 with national and international experts will deliver insights on cancer of the head and neck, treatment of advanced HCC, multiple myeloma, and accredited CME, and many more on the latest in oncology. So let us begin this 3-day clinical discourse. For today, on day 1 of Global OncoConversation, we have 2 lectures planned. At 3 p.m., we have Surgery for Head and Neck Cancer in the Elderly, Decision Making and Determinants of Outcome by Dr. Narayana Subramaniam. At 6 p.m., we have Recent Advances in Breast Oncoplastic and Reconstruction Techniques by Dr. Manjula Rao. So let us begin today's session. Approximately 60% of the cancer incidence and 70% of the cancer mortality occurs among adults aged 65 and older. Older cancer patients are physiologically, psychologically, socially, economically, and culturally heterogeneous. As a result, there is a complexity in the care of older cancer patients that deserve to be addressed through research on this growing segment of the population. To tell us more on this, we have with us today Dr. Narayana Subramaniam. Dr. Narayana is the consultant and head of department, Head and Neck Oncology, Sri Sankara Cancer Hospital, Bengaluru. Dr. Narayana Subramaniam specializes in ablative surgery of the oral cavity, oropharynx, thyroid, and anterior skull base. His research interests include oral cancer staging, patient prognostication models, oral cancer in young and non-tobacco users, oral cancer immunology, and molecular pathways in chewing tobacco and areca nut users. Dr. Subramaniam has published over 110 articles and edited a textbook titled Comprehensive Management of Head and Neck Cancer. He has received several prestigious awards, including the Bharat Chikitsa Puraskar National Award and the Nielsen International Best Research. I would now request Dr. Subramaniam to commence with his session. It's a pleasure to have you here.
Hi, everybody. Thanks for tuning in. So my name is Narayana Subramaniam. I'm a head and neck oncologist at Sankara Cancer Hospital in Bangalore. And today my talk is on surgery for head and neck cancer in the elderly, decision-making and determinants of outcome. So the outline of my talk broadly is an introduction, why I'm covering this in the first place, why it's important for us to think about what is the definition of elderly, what are the physiological changes versus physiological age versus chronological age, and what are the implications that there are for the doctors and for the patients? What are the patient motivations towards surgery and treatment? What are the considerations when we're looking at fitness for anesthesia, general anesthesia in particular? What are some of the surgical considerations that we are thinking about as head and neck oncologists when we are operating on patients in the elderly age group? I'll then share some literature with you on outcomes and determinants of outcomes. What are the considerations in salvage surgery? So patients who have already been treated once, either with surgery, radiation, chemo, radiation. How do we choose these patients carefully for surgery? And what are the things that we need to think about and discuss with them? And finally, who are the patients who we don't operate on? So, what are the indications for non surgical treatment? How and when do we choose these patients? So, starting off, so as we know, head and neck cancer is a major problem in India. It accounts for almost half of the cancer burden. And almost 15% of these patients are in the elderly age group. So, the definition here is 70 plus. As we know, the incidence of cancer is increasing every year, and also the life expectancy of the Indian population is increasing. So, we are expecting to see more and more patients in the elderly age group with head and neck cancer. And since our treatments are getting more effective, we are also seeing a lot of these patients having recurrent cancers. So, patients who have already been treated once presenting to us with recurrent cancers requiring complex treatment. So, it becomes very important for us to understand this age group and why it's special, and think very carefully about who we offer surgery to and who we don't. Unfortunately, most of the cancers that we see in head and neck in the Indian subcontinent do present at an advanced stage, and there's no difference in the elder age group. So, majority of the patients that we see in the elderly age group present with stage 3, stage 4 cancers, and that poses a challenge to us because they require multimodal treatment. So, as a result, it is inadequate to treat them at surgery alone. Often they're going to need radiation and chemo radiation after the surgery, and their ability to tolerate that is a very important consideration before we set off to treat them. Another important thing that we need to realize is that clinical decision making in this age group is very different and difficult. So, unlike other cancers, where we sometimes decide that it is reasonable to not treat patients in the elderly age group, for example, prostate cancer or pancreatic cancers, where we have a reasonable way to palliate these patients. So, in prostate cancer, for example, we have hormonal treatment. In patients with pancreatic cancer, as opposed to surgery, we might offer stenting and pain relief. Palliating head and neck cancers are very difficult. So, as they progress, they interfere with speech, they interfere with swallowing, they interfere with the patient's appearance. Patients often develop bleeding, they often develop infections, they have malnutrition, weight loss, aspiration pneumonia, and then they often have very painful, debilitating ends. So that makes this group of patients with cancer very difficult to manage. So treating them, of course, requires considerations, but not treating them also can be devastating. So it's very easy to say that these patients are high risk, we probably should not operate on them, but very often that the alternative that they face is very challenging. So we need to be careful, obviously, in choosing who are the patients we operate, but we also cannot rule out surgical treatment arbitrarily because the alternative therapies are few and far between. Another important thing is that multiple audits from different parts of the world have shown that elderly patients receive suboptimal care when it comes to cancer. It's not just head and neck cancer here, it's all the cancers. Unfortunately, multiple studies in India and abroad have shown that when you compare to the standard of care, whether it's the NCCN guidelines or local guidelines, very few patients in the elderly age group actually receive the treatment that they require. And I think as clinicians, part of this is our fault, at least. And the reason why these patients receive suboptimal care is because of some reluctance in the medical community to treat these patients with aggressive treatment. And this, I think, stems from a few reasons. One is, the expectation of limitations in terms of life expectancy. So you have an 80-year-old patient, you're not really sure how long they're going to live. So it often is simple to say, why should we treat them? Anyways, they may not live very long, but it's very difficult to determine that. It's very difficult to determine an individual patient's life expectancy. As we know, treating one patient and treating the community are very different. So the life expectancy in India is 62, 63, But if you do get a 75 or an 80-year-old patient who's very fit, I don't think it's reasonable to say, should we really be treating this patient? We don't know how long they're going to live. Another concern, obviously, is treatment-related morbidity. So all of our cancer treatments, whether it's surgical or non-surgical, do have significant treatment-related morbidity, if we are being honest with ourselves, and the patients have to tolerate this. So in the younger age group, sometimes this is accepted, especially in terms of cancer treatment, as the cost of doing business, or the fact that cancer is a horrible disease and treatment is aggressive. People are likely to accept morbidity, but the question arises when the patient is older, whether they'll be able to withstand this, whether it's surgery or radiotherapy or chemotherapy. We question whether they're going to be able to tolerate this treatment and whether it makes sense to put them through it. There are several misconceptions in the medical fraternity about poor patient compliance, and there are some good studies on this as well. So it's believed that patients in the elderly age group are not compliant for whatever reason. We assume that they will not follow instructions, they won't follow the treatment, they'll default. But that's probably unfounded. There will be individual patients who are not compliant, but as a whole, the elderly age group is just as compliant about cancer treatment as any other age group. And another issue that we have is there's very poor representation in clinical trials. So a lot of the clinical trials, um, especially the ones that are done for newer medications, basically choose very fit patients, the so-called marathon runners of our society, in order to prove that one treatment is better than the other. So that predicates on the patient tolerating the treatment. So patients are chosen very carefully for these clinical trials. So patients who are over 70, over 75 often are not represented in these trials. So as a result, as oncologists, we are a little hesitant to extrapolate the results of these trials into the elderly population. We say that there is insufficient data to say whether these patients respond well to the treatment or tolerate it, and therefore they get suboptimal treatment. So there are many things that we're dealing with, many medical and non-medical considerations, but this basically is the background of what I'm going to be talking about and why it's important for us to consider in our day-to-day practice. Now, to start off quite simply, what is the definition of elderly? So this changes depending on which part of the world you're from, and I think depending on how old you are. So there are several definitions. So some authors say that between 65 and 80, the WHO has a different definition, ASCO has a different definition. But I think most people agree around 70 years is a reasonable definition of elderly. And this came from an EORTC Elderly Task Force paper. The reference is given below. And the reason for that is because 70 years of age is a reasonable cutoff that represents an alteration in both physiological status and response to treatment-related toxicity. So it represents the patient's physiological baseline status and how that responds to the treatment-related toxicity. And that's basically the concern for all of us. Now, a tricky situation here, of course, is geographical heterogeneity in life expectancy. So in India, for example, life expectancy is 62, 63 years old. In Australia, it's 82, 83 years old. So are you going to treat a patient differently based on life expectancy? It's probably not sensible to do that, because here we have to understand that there's a very big difference between a community approach, so approaching 100 patients, but as oncologists, we really have to look at each individual patient. We have to look at personalizing treatment and choosing the best treatment for that individual patient. So I think it's relevant, even if you have a 90-year-old patient or 95-year-old patient in a country like ours, where the patient's already exceeded life expectancy by 20, 25 years, you have to really look at that patient critically and not extrapolate someone else's data to them. Now, again, very important is the difference between physiological and chronological age. I think this is something that all clinicians have experienced. You have a 60-year-old patient who really looks like they're 80. They're wheeled in a wheelchair. They've had multiple strokes. They have dementia. They're not very responsive. Conversely, you have that 80, 85-year-old patient, who does 100 Surya Namaskars every day, who is absolutely fit, whose pulmonary function test would probably be better than yours. So I think we have to make that distinction. I think it's getting more and more hard to come up with an arbitrary chronological age cutoff for any kind of treatment. Personally, I don't believe in that. I think that each individual patient has to be considered, and the treatment that has been offered to them, you really have to consider. So I don't think that we can afford to have arbitrary age cutoffs because every patient is fundamentally different. Of course, from a surgical standpoint, the American Society for Anesthesiology, which is the ASA status, and the comorbidity indexes often reflect this. So what that means is as patients grow older and senescence sets in, they often have more comorbidities. So now we are in the age where it's expected that for each decade of life, the patient adds on one comorbidity. So at 30, you'll have one lifestyle disorder, at 42, at 53, etc. So we are getting older as a population. We're having a lot more non-communicable illnesses, and comorbidity indexes and ASA status often reflect that. So the elderly patients may have higher ASA status and comorbidity indexes. But what is often difficult to represent is physiological reserve. So ASA status and comorbidity index basically tells us that at this point in time, pre-treatment, what is the risk of the patient when they're put under anesthesia. But what we need to understand is what is the patient's physiological reserve. And what I mean by that is rather than looking at the patient at this point in time, what is the likelihood that they would tolerate treatment that puts them under physiological stress? And this is a much more difficult question to answer, I think, because the manifestations of physiological and surgical stress are very different in different people. So surgeons would understand this. There are some young patients who do have a lot of physiological disruptions after major surgery, and there are some older patients who sail through. So this is a lot more difficult to quantify. It's definitely something that we all understand, but it's getting harder and harder to put your finger on it. But we have to think about this. How likely is the patient going to tolerate the treatment? And what is the impact of our treatment on their future health, not just what is their status currently? And also another point here that I'd like to make is it's a little confusing to see how do we weigh comorbidities against an age group. So if you have a 60-year-old patient with poorly controlled diabetes and you have an 80-year-old patient with poorly controlled diabetes, do you weigh them equally? Do you weigh them differently? How do you justify that? How do you standardize that? So that's again a different question altogether. So what I'm trying to focus on here is basically the context that I'm trying to set is that I'm looking not at the very, very fit elderly patients who look like your 30 or your 40-year-olds who will sail through treatment. And I'm also not looking at patients who are very unfit. So people who are in a wheelchair, an old boss of mine from Australia used to say, not fit for a haircut. So a patient who's really unfit for any kind of surgical intervention or either of the outliers. So the very fit or the very unfit patients, we know what to do with. We know that we shouldn't be operating on a patient with ECOG3, for example. That's best supportive care according to NCCN. And we know that the very fit patients, we can operate on them, but we are looking more at the patients in the middle. I'm going to be looking only at radical intent treatment. I'm not talking about minor surgeries, a small partial glossectomy, hemithyroidectomy that you can all do in 30 minutes or less under local anesthesia, really not considering those patients during this talk. And the exclusions are also low-grade cancer. So low-grade cancers are benign tumors, not sure if they're malignant, whether you have to touch them, not talking about those patients at all. So what I want to start off with here, and I really want to stress on, is patient motivation and family support. So as surgeons, obviously we know the importance of a pre-anesthetic evaluation and anesthetic fitness. We know the importance of rehabilitation, the importance of physical exercise, chest physiotherapy, so you don't get atelectasis, moving around so you don't get deep vein thrombosis. But I think what we don't talk about enough is patient motivation and family support. And I think that's especially important in cancer because the duration of our treatment can be very long. The recovery from our treatment can be very long. And these are the things that play a big role. So surgery in our case is just the beginning. Putting a knife on a patient is just one part. Getting them off the table into recovery is just the very beginning of their treatment and their long road to recovery. So we always have to remember that we are not worried in today's day and age of intraoperative deaths. Thankfully, those are very rare. And if we do have them, it's important to introspect and see that if we miss something preoperatively, or it was a case of poor planning or execution. So I think most of the trouble for us starts immediately after surgery, unless we're badly planned. So we shouldn't be badly planned, but everything starts after surgery. So there are certain surgeries, of course, in the head and neck, which are high demand. And by high demand, I mean high physiological stress to the patient and high demand for rehabilitation after the surgery. And what I mean by that is, for example, oral cavity surgeries or oropharyngeal surgeries, where the patient might have a tracheostomy. They need to do speech and swallowing rehabilitation. So you can decannulate them, remove the tracheostomy, remove the feeding tubes. Reconstructive surgeries where the patient has had, a flap from the limb, a fibula or an anterolateral thigh flap, where they need to move around the leg. The leg will be painful. It may hamper mobility, but you really need to get them moving around to prevent deep vein thrombosis. Thoracic surgeries, if you do, for example, a laryngopharyngectomy and a gastric pull-up, these, of course, can affect the patient's ability to breathe. There can be pain. If you do a transhiatal esophagectomy, the patient's lung compliance is impacted. So those are very clear to us as high demand surgeries. And these are the ones that we really have to be, very careful about selecting patients for. And then you have the lower demand surgeries, basically, like thyroid surgeries. So barring any major complication, a recovery from a thyroidectomy is limited. Recovery from a neck dissection is limited, other than pain. Salivary gland cancers, again, parotidiectomy, radical parotidiectomy, fairly straightforward to recover from. And of course, skin cancers may not be a major concern other than infection. I think it's very important to be realistic about perioperative rehabilitation and the road to recovery. So there is a role for optimism always as an oncologist, but you also have to be pragmatic. You need to be realistic with the patient and the family about what to expect, how long it's going to take them to recover, and what they need to do. So it's very clear what we need to do as surgeons, but it also needs to be clear to the patient what is expected of them. Are they going to have to go physical rehabilitation? And is that going to be difficult? Are they going to have to get through speech and swallowing? Right? Are they going to be in a lot of pain post-operatively? I think we need to be honest about this because I, as a surgeon, hate it when the patients have surprises after surgery. So, for example, inadequate counseling, saying that it's a small procedure, they'll sail through it, and then the patient starts struggling post-operatively. That's a very bad situation. And once the patient is in that situation, it's really hard to navigate them out of it. Uh, the road to recovery for everybody is a little different. And I think it's important also to explain this to the patient, that often it's a spectrum. So patients, may sail through it, may struggle a little bit. Some of them may go home with feeding tubes, may go home with tracheostomies, but it's important not to struggle, not to diminish the struggle or to minimize the struggle and put pressure on them to get early rehabilitation and remove all the tubes, for example, because that might predispose to complications like aspiration pneumonia or electrolyte disturbances if you remove the feeding tube and the patient isn't able to eat adequately. So you can't stress them into being rehabilitated early. You have to be realistic with them. It's also very important to understand an individual patient's motivation. So I have a rule of thumb that I follow, not sure if it applies to everybody else, but if I have an 80-year-old or older patient who requires a major surgery, a major resection, I will not offer them surgery before I've met them twice or thrice. The reason for this is simple, because if they make an instinctive spur of the moment decision to undergo surgery, it may not be the right choice for them. So I want to understand, what the patient's background is, I want to understand what their motivations are, how likely they are to be motivated towards recovery. Everybody wants to be cured, and I think that's obvious. But how hard is the patient willing to work, and how much discomfort are they willing to endure? I think is a very, very important thing that you have to understand before you put a knife on another human being. So I find this helpful personally, that I meet a patient twice or thrice before I offer them surgery and discuss the logistics of surgery. Meeting them twice or thrice gives me some idea that they are motivated towards the treatment. They've come and met me multiple times. They have time to consider things in between. uh, Give them some space and time and clarity to consider all of these. I often tell patients to think about it and get back to me. I don't want any spur of the moment instinctive decisions, because often they're wrong. Very often we are breaking the news of cancer diagnosis, so it's a very emotionally charged moment, and patients make decisions that they may regret later on. In the elderly age group, depressive symptoms are common and they do not appear typically. So it's important, especially if you're dealing with somebody who's just been diagnosed with cancer. Up to a third of patients have depressive symptoms. So if they're depressed, they can have generalized anxiety, depression, or they can have just depressive disorder. You really have to understand that, and you have to get them treated, because otherwise what happens is post-operatively, it becomes very difficult to get through to them, to motivate them, and basically to rehabilitate them. So you need to treat that before, you need to get counseling done beforehand, make sure that they're in a good frame of mind to receive instruction and support. Familial and other support systems also extremely important. Patient might need repeated dressings, has to come back to the hospital again and again. Somebody has to bring them. Very often they can't do it on their own. Even if they don't have family, if they have a close social support system or a circle, somebody who lives next door, friends, family, very important. Radiotherapy, often 6, 7 weeks after surgery, somebody needs to bring them. So if they don't have these support systems, compliance is automatically going to be poor. Now, what I want to talk about also is something called frailty. So this is a relatively recent concept. It's not very old and it's not very new either. So basically, the idea of frailty in the elderly age group is not just the patient's current state of health, but the likelihood that the patient can withstand an injury to that state of health and how likely they are to rebound from that. So this was a nice article that I found that I suggest you all go through. It was published in Anesthesiology a few years ago, and it's called Accuracy and Feasibility of Clinically Applied Frailty Instruments Before Surgery. So this is a systematic review and meta-analysis of all of the frailty instruments that are used for pre-anesthetic evaluation. So they looked at 35 instruments, and basically the endpoints that they were looking at are prediction of mortality and non-favorable discharge. So for example, patient being discharged, with in a compromised fashion, with their performance status impaired. So what they found was that the clinical frailty scale was the most accurate one that could be easily applied. So this is the clinical frailty scale that goes from 1 to 9. So 1 is very fit. People who are robust, active, energetic, motivated tend to exercise regularly and are among the fittest for their age. It goes down this way to fit, managing well, living with very mild frailty, living with mild frailty, all the way to terminally ill. So a lot of the patients that we find and consider for surgery are in the 2 to 6 category. We are not likely to offer patients 7, 8, 9 with radical treatment. They'd probably fall in the ECOG 3 category, so are not likely to offer them any extensive treatment. But we are essentially dealing with 2 to 6 in our daily practice. And it's important to read through this to understand the subtle differences between them, right? And the ability of a patient to withstand surgical stress and physiological stress and recover from that is basically what we are trying to look for. So it's a more objective way. So there were, I think, older ways of doing this. For example, having the patient walk up the stairs, to meet the anesthesiologist who was on the first or the second floor of the hospital. You would have the brisk walking test. You would have a mini mental scale examination to assess cognitive function preoperatively. So all of these, of course, have their value, but this is a reasonably objective way that we could at least slot a patient into one of these categories with a certain degree of accuracy. So important to think of when you're planning for a patient with surgery. So the next, of course, is fitness for anesthesia. So as surgeons, this is something that we understand well. So I'm not going to talk about everything that we consider, starting with ASA and all of these things, but I'm going to talk specifically from the context of an elderly patient for major surgery related to head and neck cancer. So on the right side, we have the Charlson Comorbidity Index. So this is basically the comorbidity index, which is followed around the world. It's probably the most popular one that is quite standard. So it categorizes patients based on a scoring that has been designated for each individual underlying comorbid illness. So if you had a prior myocardial infarction, it's a score of 1, congestive heart failure 1, peripheral vascular 1, dementia 1. So as you go down the list, you have diabetes, you have a cerebrovascular event, which are 2, moderate to severe renal disease is 2, and then you have a lymphoma, which is 2, moderate or severe liver disease is 3, a metastatic solid tumor or AIDS is 6. So as you add up all of these for a patient, you come up with a final CCI, which is the score, and that correlates roughly with the postoperative mortality. So it gives you an idea of how likely the patient is to tolerate major treatment. Another important assessment is blood loss. So as we know, patients in the elderly age group are sensitive to blood loss simply because a contraction in the intravascular volume is likely to disturb their cardiovascular output and cause issues with hemodynamic stability. When there are sudden losses in intravascular volume, there is a predisposition towards arrhythmias and a predisposition towards cardiac ischemia. So obviously, elderly patients do not tolerate blood loss as well as younger patients. So it's important to think of how bloody our surgery will be and plan accordingly. So if there is a way, for example, to reduce the amount of blood loss, always very important. And basically, in head and neck surgery, it's probably not as relevant as other surgeries like cardiac surgery or liver surgery, where you can use cell savers and things like that. Also, as you transfuse a patient more and more blood, the risk with each transfusion adds up. So the likelihood of having complications of massive transfusion, transfusion related acute lung injuries and other things can happen. So you need to anticipate these things. You want to avoid blood loss as possible. Be very careful with your blood loss and be very careful with sudden disruptions in hemodynamics. So what I mean by that is if there is anticipated blood loss, it's important to plan it so the patient doesn't suddenly lose huge amounts of blood. There's no sudden contraction in the intravascular volume. This predisposes the patient to cardiac events, which can be costly in this age group. Another important consideration is lung compliance. So very often in our patient group, patients have a history of smoking for many years. So they might have emphysema, they might have some underlying lung disorders. So lung compliance can be an issue. Post-operatively, there is a concern of prolonged ventilation, and this predisposes the patient to the risks like ventilator associated pneumonias and other issues. So it's important to see whether we can strengthen their lung compliance preoperatively using spirometry or other techniques. If you can do that, if you have a window, it's important to do that. Another important consideration are the surgical complications related to your particular surgery. So for example, if you are going to have, a risk of if your patient, for example, has a carotid stenosis, for example, and there's a chance that you could have severe blood loss and the patient could have a cerebrovascular incident. So that is a major consideration that you have to anticipate and you have to factor into your surgery. If you are going to have, for example, injuries to the vagus, if you're going to sacrifice the vagus nerve in a radical neck dissection, the patient is going to have postoperative vocal cord palsy, and they're going to have possibly some microaspiration. So these are individual risks that you have to think of and the complications that you have to consider. So a patient who already has poor lung compliance is not going to tolerate even a little bit of aspiration. So even if they have microaspiration, that is a major problem. So you might want to consider doing a tracheostomy, for example. I think ultimately what it boils down to is the last point. So what is the risk benefit ratio of your surgery for that individual patient? So the point that I want to make is as we go down the list, right? So as you have, for example, a patient with multiple comorbid illnesses, and then you have significant amount of blood loss, and you have poor lung compliance, and the complications of your surgery are likely to be, quite heavy for the patient. You have to look at the risk benefit ratio for that individual patient. So what is the likely endpoint you see for this patient? Are they likely to make it out of the ICU? Are they likely to go home? Are they likely to go home in what state? So an important part of our surgery is not just removing the cancer, but ensuring that the patient has a reasonable quality of life afterwards. Because if the patient doesn't have a good quality of life, the amount of rehabilitation that they can do in the elderly age group is very limited. So to get them to a state of functioning that they were in prior to your surgery, prior to the cancer, is going to be very, very difficult. So as you go down this list, if the likelihood is that the patient is not going to do well, then you probably shouldn't be operating them. From a surgical standpoint, prehabilitation is something that has been discussed for a few years and is quite interesting. So prehabilitation basically refers to all of the rehabilitation that's done actually before the surgery. So all of the planning and the assessment for rehabilitation is done before the patient goes under the knife. Uh, Part of this is, for example, a comprehensive geriatric assessment that helps pick up on issues that we may not as oncologists. So the geriatrician makes a formal assessment, identifies deficits that need to be assessed and need to be treated. So big parts of prehabilitation, for example, are reducing the anxiety associated with surgery, correcting any malnutrition that the patient may have, improving lung compliance, for example. So all of these things play an important role in how quickly we can get the patient out of the ICU, how quickly we can get them back on their feet and into a functional state. So there have been some studies here, and I just put one up here. So the reason why I put it up is it's almost 10 years old. So it's been discussed for a while, and this is with respect to colorectal surgery. There are not too many specific studies on head and neck, but I think a lot of things we can learn from the other specialties. So this is a study basically where they looked at trimodal prehabilitation on functional recovery. It was a clinical trial, and they found that when patients did go through a specific protocol, they did do much better. Objectively, they did much better after surgery. So it's probably something that we should think of, maybe at least on an individual basis, where we have some kind of rehabilitation program for our elderly patients. Whether it's at its simplest form should be, like a nutritional evaluation, psycho-oncology evaluation, and a geriatrician's evaluation. And then we go from there. Some kind of assessment of physical fitness and recovery. I always find that it's helpful to meet the rehab team before surgery, whether it's a swallowing therapist or the physiotherapist, because it helps build up a rapport, and the patient's rehab is much better once they're an inpatient. Duration of anesthesia, very important. Very important surgical considerations. Longer the anesthesia, more likely the patient is to have complications. But I think there's a caveat here. When we're looking at the duration of anesthesia, we need to basically the patient is during anesthesia. So doing a very short, fast, messy surgery where the patient has a lot of blood loss and hemodynamic disruption is definitely worse than doing a longer surgery that is more neat, and is more meticulous and has less postoperative complications. So there is a little bit of a balance here. We shouldn't be in a tearing hurry, We also shouldn't be leaving the patient under anesthesia for long periods of time. So blood loss, of course, obvious to us, especially when you have to replenish patients in the elderly age group. We may not be able to replenish as quickly, especially if they have cardiac issues, they have renal issues. You cannot transfuse them so easily, so they might end up on inotropes for a longer period of time. Hemodynamic disruptions, elderly patients do not tolerate well. So if the patient suddenly has intraoperatively, you will definitely see that on the monitor. They will have arrhythmias, there will be cardiogenic shock, you may even have cardiac arrest. So that is something what you have to avoid at all costs. And I think that comes with very good surgical planning. So you plan out the critical steps of the operation, you approach the most dangerous areas of your operation with the most exposure, have your vessel clamps ready, just be sensible and well planned. Extent of the surgery, if you can reduce it, it's oncologically sound, excellent, as to a certain degree. Of course, small T1 tongue, you may do a neck dissection in a younger patient. You think you may not need to do it in a 90-year-old patient. Talk to the patient, discuss the risks and the benefits, and go ahead. ERAS, of course, very important in terms of anticoagulation, in terms of early mobilization, in terms of chest physiotherapy. But in head and neck specifically, the issue with ERAS is early decannulation may be costly because patients have difficulties swallowing, so they may not be able to take enough through the mouth. They might have electrolyte disturbances, malnutrition. They might get readmitted a week later, because of Similarly, for decannulation, you have to be worried about microaspiration. If your elderly patients aspirate, they will not tolerate it well compared to younger patients. So the caveat here is you may have to decannulate patients a little slower, remove the feeding tubes a little slower here, which is not in accordance with ERAS. So just some data basically that we worked on. So this was a study that came out of Amrita that we published. So we looked at perioperative outcomes following major surgery for head and neck cancer in the elderly. It was an institutional audit and a case control study. So in this study, what we did specifically is we looked at elderly patients over the age of 70 who had major surgeries. And again, the extent of the major surgeries, a lot of them are flaps, a lot of them were, thyroidectomies with neck dissections. So patients who had anesthesia of 3 hours or more, patients who had complex surgeries, laryngectomies, tracheal resections. And we basically did a case control study where we looked at the same surgeries done in the younger age group. Basically, we wanted to see how safe it was in this age group and if they had an increased risk of death or complications. So what we found in this study was that elderly patients had a reduced performance status and more comorbid illnesses. So this sounds a little obvious, but what it told us was basically that this was more reflective of real world data. So if we had elderly patients with a comparable performance status and as many comorbid illnesses or fewer illnesses than the younger age group, then that would mean that we had cherry picked our elderly patients very carefully for surgery, and it probably wasn't reflective of what you would see in the community. But thankfully, that wasn't the case. So what we found is that they had a comparable intraoperative course. So like I said earlier, the problem is not during the surgery. Very often we think that the general anesthesia has the problem, but they had a comparable intraoperative course when we compared them with the younger age group. But they did have a longer median hospital stay. They had a longer ICU stay. Again, of course, it's likely that they had post-operative disruptions in either hemoglobin or, they required more inotropic support. For whatever reason, they needed a little more intensive care. Interestingly, they also had longer tracheostomy dependence, and they were often discharged with feeding tubes. So the point here is, again, when we think of ERAS, we want to think of getting the tracheostomy and the feeding tube out as soon as possible. But here it may not be feasible or wise in the elderly. So whatever your objective way of assessing the time for decannulation is in your patients, you are probably going to need to keep the tracheostomy for a bit longer because there will be some swallowing issues. There will be, some disruptions in the supraglottic anti-aspiration mechanisms after major surgery. And similarly, the ability of the patient to get back to a full oral diet takes longer. So you may have to discharge them with a feeding tube. It's safer than removing the feeding tube and asking them to come back and expecting them to come back because they are nutritionally depleted. Similarly, you don't want your patient to be decannulated early, but to have an aspiration pneumonia. So again, a delicate balance there. Very interestingly, what we found is that the elderly patients had a higher incidence of post-operative non-fatal cardiac events. So this was an incidental finding because one of the anesthesiology registrars in Amrita was doing a thesis and they were looking at drop eye levels in routine post-operative surgery, post-operative settings in the ICU. So what we found is a lot of patients without a pre-existing cardiac risk. So patients who are not diabetic, patients who are not hypertensive, did not have coronary artery disease, had post-operative elevated drop eye levels. And what we found is they had a higher incidence of non-fatal cardiac events. So non-fatal cardiac events included shocks, it included arrhythmias. Basically, I think this was a reflection of the post-operative physiological stress that patients were having difficulty dealing with. So what we found was that patients had cardiac events even in the non-high risk category. So this was an interesting finding and something that gave us food for thought. This was another study basically where I worked in Lifehouse, where we looked at microvascular reconstruction of head and neck defects in the elderly. So why we look at microvascular reconstruction and free flap specifically is because these are kind of a surrogate for major cases. So the operative time is longer compared to other groups. The hemodynamic disruptions can be longer. The post-operative recovery is longer. So here, the definition of elderly was above 75 years of age. And this is an Australian population where the life expectancy is 82. So they had a higher overall complication rate. So the odds ratio was 1.7, but this was restricted to medical complications. So they were twice as likely to have medical complications like dyselectrolytemias, like renal dysfunction, cardiac dysfunction, but not surgical complications. Reconstruction of defects from cutaneous malignancies, so Australia is the skin cancer capital of the world, was more common in the elderly age group, but there was no difference in the complication rate when mucosal and cutaneous subgroups were separated by age. So, if it was an oral or an oropharyngeal or a laryngeal cancer versus a skin cancer, there was no increased risk. ASA4 status was weakly associated with surgical complications, but the Charlson's comorbidity index and elderly age was not associated with any outcome. Median length of stay was similar between age groups. So, of course, if you have an older patient with more comorbidities, that's obviously bad, but may not correlate well if the patient doesn't have major comorbidities. So again, we are looking at better ways to identify patients who fall in that gray area. So patients who are not very fit, not very sick. How do we stratify that group better? Just a couple of, I think, minutes on salvage surgery. So salvage surgery, as you know, is patients who have received some kind of definitive treatment. So not chemo alone. If the patient has been operated once or they've gotten radiotherapy previously, it's called salvage surgery. So these are patients who are treated previously. So the risk of complications is higher. So I think number one, the most important thing is what is the patient's willingness for treatment. So in our own studies, we found that almost 50% of patients who have previously been treated and have recurrent cancers don't want treatment. Even when they are candidates for curative intent treatment, they just don't want it. They are fed up, they're done, they cannot withstand any more treatment. So you need to be very clear on what the patient wants and understanding it a little better. So if they do not want treatment, definitely not a candidate that you want to put through salvage surgery. If the patient has had prior radiotherapy, elderly patient, more chances of wound healing, more chances of dehiscence, more chances of complications. And you need to talk about this to the patient and they have to be willing to go through this. You really have to understand what the patient's interest is in treatment, what their motivations are. Carotid stenosis can be a big problem in elderly patients, especially if they've had radiotherapy. can affect our ability to do reconstruction because we have to attach our flaps to the carotid circulation, can be very, very difficult. So again, if if you are going to operate on this patient, these patients get a complete evaluation, loop in a neurologist, interventional neurologist, see if operating is a good idea. The worst thing you can possibly do is give your patient a hemispheric stroke after surgery. Important to have backup plans. The tumor is bigger than you thought always. Your margins are always bigger than you thought when it's a salvage case. So if your reconstruction plan isn't working, you have to have a backup reconstruction plan. And most important here is the patient has to be willing to and fit for that backup plan. So very often you plan for some local rotation flap or a local regional flap, and then suddenly you need a free flap. It's very bad in these patients to change a plan on table. That is really going to put you at risk for a lot of complications. Important to think of what is the compliance with adjuvant therapy. So if you have an advanced oral cancer with big lymph nodes, extranodal extension, are you really going to be able to cure your patient with surgery alone if the patient doesn't go through radiotherapy? So what is your likelihood if your patient is not going to comply with future therapy? Is your surgery really going to be useful? In salvage, usually it's not, because if you don't consolidate with adjuvant therapy, they're probably not going to be cured. So you need to consider that as well. And finally, most importantly, what is the likelihood of cure? So surgery is not ever in oncology or anywhere an academic exercise. It has to serve a purpose. It has to be meaningful for the patient. So if you're putting the patient through salvage surgery and they're elderly, are they likely to be cured? Is it a recurrent residual cancer? Is it a second primary tumor? Huge differences here in terms of prognostic implications. So you have to think of all those things and discuss them with the patient. Now, where do we offer non-surgical treatment? Also very important. So for some relatively non-aggressive cancers, we do have some patients, who are 90 plus, papillary thyroid cancer with nodal metastasis on follow-up. So they're the conventional papillary thyroid cancers. Keep them on close follow-up. They're not progressing. Leave them alone. You're not probably going to change the course of their life. It's the same with prostate cancers in the elderly. So it's important to be very clear in your mind, though, if you are following up these patients, are you going to intervene? So if you do have a patient and the tumor starts growing, is it that you're going to operate, or is it that you're going to accept that the patient doesn't want the treatment? The patient is going to accept that they don't want the treatment and they receive best supportive care. Because herein lies the problem. So if you are planning to intervene and then the patient becomes unresectable, then you're in trouble. So it's probably more likely if the patient wants to follow up and you want to follow up that the patient's never going to opt for surgery. And that's okay, but you just need to be very clear about that in your mind. Another important issue is how informed is informed consent. So in head and neck cancers, like I said, unlike other cancers, palliative treatment or best supportive care is really not a good option in many patients. You have issues with speech, swallowing, bleeding, uh, aspiration pneumonia, carotid blowout. It is really very miserable. So it's really hard, without scaring the patient, to make them aware of what they're going to face if they opt not to take treatment in an aggressive cancer. But if they understand all of these things and they really do know what they're in for, I think it's important to respect their autonomy and accept that they don't want any treatment. So your role here, I think, it's my personal opinion, is to give them all the information, make sure that they understand it, that they process it, and if that's what they want, respect that. Palliative treatment and end-of-life care, again, a very important part of any oncologist's life. So you have to understand what are the palliative treatments that are suitable and not suitable for the elderly. You end up giving metronomic chemotherapy and less toxic treatments, shorter courses of radiotherapy. If you are not going to cure the patient, definitely doesn't make sense to be more aggressive and give the patient a lot more toxicity. End of life care, best supportive care, these are very valuable. We tend to undervalue them significantly. But, having a feeding tube, wound dressing, um, nutrition, high quality nutrition, pain management, all of these are very, very important. So it's not just quality of life, it's quality of death as well. And very often we can intervene early before the patient has these debilitating symptoms. Whether, for example, patient has bleeding, hemostatic radiotherapy is one possibility, or if you have the option of embolization before the patient starts bleeding, much better rather than after the patient starts bleeding. So anticipate the issues that your patient is likely to face when they opt for non-surgical treatment and follow them up closely. It's not that once they become a non-surgical treatment, they fall off your radar and you don't care about them. That's not the right way to go about it. Most important thing that I want to end with is there is no such thing as palliative surgery in head and neck cancer. It does not exist. If you cannot get an R0 resection, you cannot remove the whole tumor. There is no value in removing most of the tumor. It's not like a toilet mastectomy that alleviates symptoms. In head and neck cancer, the tumor will grow back immediately. If it's an extensive cancer that you cannot remove completely, the patient will recur immediately and the local regional symptoms will be devastating. So there is no role for palliative surgery. So you really, really can't think that I'm going to remove this cancer, basically to improve the patient's quality of life. Noble thought, but it doesn't work that way. Thanks. Happy to take any questions.
That was indeed an enriching session with lot of learnings. Thank you so much, Dr. Subramaniam. We shall now move towards the question asked by the audience. My first question to you is, can you explain how the decision-making process should be shared decision-making and not only the decision of the doctor in cancer cases?
Yeah, so I think that's a good question. So basically, you're asking how decision-making process should be shared rather than just the decision of the doctor. So I think sometimes as oncologists, we become a little too dogmatic in terms of, what are the guidelines, what is the ideal treatment that needs to be followed. But at the end of the day, we have to understand that it doesn't apply to some section of the population. And what I mean by that is in two particular areas. Number one is, will the patient tolerate the treatment, right? So are they going to be able to receive the treatment? Are they going to be able to tolerate the side effects? And number two, unfortunately, in our country, finances are a very big part of that. So as much as we would like to treat every patient in an ideal fashion, especially in the elderly age group, it's important to understand that we cannot treat patients according to the guidelines in every single case. So I think here it's really important to understand, number one, what does the patient want? Number two, what does the family want? And I think it's basically, it needs to be a consensus. So as an oncologist, your role is to offer your treatment options. Number one is the best, number two is next, number three is, probably the least best. But finally, it's the patient's decision, it's the family's decision. It's important for you to make sure they understand, especially if they're opting for non-curative treatment or suboptimal treatment. As long as they understand it and they realize what it entails, then it's fine, not an issue. But I think it really needs to be shared decision making for everybody, not just in the elderly, but especially in the elderly.
Very well answered. Moving on to the next question. How should physician assess the benefit that patient would gain after the treatment? What are the important factors that matter?
Okay, interesting question. So in the elderly, in general, the way we look at it is, if you have a patient in the elderly age group with a good quality of life, very many patients will come to you and say, I've lived for X number of years, 75, 80, 90. I'm okay if I die tomorrow. Now, that's a bit of a fatalistic worldview, but what we need to understand is that if you have a patient with a good quality of life, your job is to maintain that quality of life. The patient has no frame of reference for a patient who dies of advanced head and neck cancer. We have a frame of reference. We know what that looks like and we know it's miserable, but the patient doesn't have that frame of reference. So I think the point here is you have to understand what are the issues that your treatment is going to cause and how do you alleviate them. So for example, if it's an oral cancer resection, you're going to remove part of the mouth. How are you going to replace that function? Will the patient be able to eat? Will they be able to speak? Will they be able to swallow? Will they look normal, right? So that is one aspect, how well you address the treatment related problems with your definitive treatment, which I think we're reasonably good at. We're still improving as we go, but we're reasonably okay with that. But then also we have to think, what are the functions the patient's going to lose and weigh them against what are the risks of the disease progressing unchecked. So again, if it's a low-grade cancer, you can probably leave it alone if it's not going to impede function. But if it's an aggressive cancer, it's an oral cancer, it's an advanced laryngeal cancer, then you have to treat it. So I think, again, here you need to sit down with the patient and understand what's important to them, understand what they value in terms of functionality, and then that can help guide your treatment.
Thank you for answering that. Moving on to the next question now. What other help does an elderly oncological patient require apart from the surgical part? How can a team of professionals help the patient?
So I think that there are two aspects to that question. So you have the in-hospital care and then the out-of-hospital care. So what I do personally is I like to keep patients in the hospital for a little longer, especially if they're elderly, and make sure that they reach a good level of functionality before I discharge them. Because in the hospital, we have the luxury of having a physical therapist, a swallowing therapist, a dentist if they have any dental issues. We have a team of doctors seeing them. We have an endocrinologist if the blood sugar is going high, or a cardiologist if, we need to figure out whether the patient needs an antiarrhythmic. So I think having a team of people to treat the patient in the hospital is very, very important when you're dealing with elderly patients. You can't do these in small setups. You can't do these without having that multidisciplinary input. But then you also have to understand, when you send the patient home, what kind of support is there. So you have obviously familial support. And what you want to do is you want to send the patient home when they need as little professional help as possible. So of course, if you have a patient who anyways, for example, is wheelchair bound or requires a walk or support for walking, they're used to that. But you really don't want to send home a patient who is not ambulant, not mobile. You want to make sure that you rehabilitate them well and send them home. If, for example, you need therapy at home, swallowing therapy, you need to plan that out before discharge. You need to talk to the family. You need to have that conversation and have a rehabilitation plan set out for them, from the time they go home, and you have to have milestones that they reach. So I think you have to be very well planned about these things. I think, to be a little more specific to your question, it very much depends on what kind of surgery you're doing and what issues the elderly patient has. But most of the time in head and neck, it is lifestyle diseases, so non-communicable diseases. So it's, diabetes, hypertension, cardiac issues, stroke, a lot of them have. They might have liver dysfunction. So you need those specialists in the loop. You need rehab specialists like your physical therapist, swallowing therapist, your dentists. You need prosthodontists, for example. So it's a big team of people, but you try to make sure that they are as rehabilitated in the hospital as possible. So when they're discharged and they go home, they need very little special care.
Well answered. Thank you so much, Dr. Subramaniam, for taking us through some interesting details of the cancer therapies in India and their future. We hope to see you again soon for DocPlexus webinars. We hope our healthcare practitioners have gained some useful insights from this lecture. Please write to us if you have any more feedback and queries regarding DocPlexus events. Until we see you again, please take care, and as I always say, happy DocPlexing. Thank you.